As a reminder, the structure of ECHO clinics, we will do introductions roll call, which we've done. We'll do the didactic presentations. This morning we have Emily Guseman and Chris Taylor who are going to present. We'll talk a little bit about their presentation as well. We'll have two case presentations, which in general should have some relationship to the topic, and so far we're pretty good. We've been pretty good about that. And we'll try to keep about 5 minutes for a wrap up. This is often the part of our clinics that's the most pressed in terms of time. People have lots of comments and suggestions about the cases, which is the whole idea, of course. So if we go to the next slide. So we are going to get this started with our presentations. And Chris and Emily, I'm not sure who you decided was going to go first. I believe Emily is going to be leading us off.
No,
is that correct?
I have Chris first.
Okay, Chris first. Okay, thank you. So these are our general disclosure statements. Adam Przinski should be available to provide some comments, especially about our case studies. Siran is also in charge of our evaluation component, and she is here as well. Dr. Bakris is not on the call today that I can see, but he is one of the future presenters. Next slide. Okay, so this is a hugely important topic, and I just want to share an anecdote. I remember speaking with Bill Hyman, who's at Baylor, a leading hypertension expert, and of course, according to most guidelines, you start with lifestyle changes for a little while, and then you switch to medications. And he felt that was a complete waste of time, that we should be very much more aggressive in terms of pharmacotherapy. However, he did acknowledge the adjunctive or additional value of lifestyle changes, and I think that's emerging as an increasingly important topic. So, Chris, I'm going to turn things over to you. You can take it away.
So I'm Chris Taylor. I'm a professor of medical dietetics at The Ohio State University. And then I've also got a joint appointment and do collaborative work with Randy Wexler in family medicine. And my work is on dietary patterns and chronic disease risk. So that's what I'll be kind of bringing this work forward today. And as Dr. Rao stole my thunder a little bit as a fun this morning. But looking at how we treat hypertension and a lot of the discussions on how we move forward with hypertension, we seem to be at this balance between how much do we promote lifestyle behavior modification, physical activity, and dietary patterns, which we'll be talking about today, as well as balancing that with pharmacologic treatment. And looking at some of these issues that we're dealing with, hypertension, diabetes, a lot of times we're trying with pharmacologic treatment to manage the physical manifestations through this medication treatment. But in some ways, it's kind of like trying to heat your house in the winter, which we can all equate to right now, by turning up the thermostat, but not closing your windows. So we're letting lots of other things in, and then we're going to try and we're going to let that cold in through the windows, but we're not going to treat the fact that the house is cold because we're dealing with open windows and a draft. So a lot of times these conversations, as Dr. Rao mentioned, go straight to pharmacologic treatment without many of these guidelines that push lifestyle behavior modification as that first line actually being implemented. So next slide, please. So there are lots of different dietary patterns that are out there being pushed currently, whether it be for high blood pressure, for the Mediterranean diet for cardiovascular disease overall, the DASH diet eating plan. All of these have these similar kinds of patterns, as you'll see. It's a heavy fruit, vegetable, whole grain, healthy fats, and then a limiting of processed meats, high-fat meats, and saturated fat sources. Sorry, next slide, please. So Lots of different data has been pushed on lots of different diets. The DASH diet continues to kind of be rated the #1 overall healthiest diet. But what you're really seeing is this consistency across these different eating plans. In reality, whatever we want to call them, the US dietary guidelines, my plate, DASH diet, Mediterranean diet, they all have these same central tenets, just slightly emphasized in a different way. Getting fruits, vegetables, whole grains, healthy fats. I think we'd be remiss if we walk down the street and ask somebody on the street, what do you need to eat to be healthy? They'd tell us fruits, vegetables, whole grains, don't eat too much fat, don't eat too much sugar. So we have the ideas out there, and that's where I think the next step has to go. Next slide, please. So the bigger challenge that we have to deal with is now, how do we translate all of these guidelines into what people are eating on a daily basis? And I think the first part is that it isn't just going to be an easy, here, these are the fruits and vegetables I want you to consume, and I want you to eat more, and I want you to eat less sugar, and these elements, where it's going to be a lot more, it's going to require a lot more time and attention in understanding what people eat, why they eat it, and what their current situation is, so they can actually do the things that we want them to do. The U.S. Preventive Service Task Force recommends that we need moderate to high intensity lifestyle behavior interventions if we want to facilitate behavior change. And this is going to require more than just some of our basic kind of education. How are you doing? I want you to do these kinds of things. And then when we look at the different recommendations that we have, they're telling individuals, all right, I want you to eat these foods. Now they have to figure out, where am I going to access these? What are my cooking skills? What's my ability to actually find this food, afford this food? So then we get into these social determinants of health, that this thread keeps coming up more and more within our conversations. And then we have to get all of these ideas of what we want people to eat. And we need to translate them specifically into food and meals, so that they can say, all right, I need to reduce my sodium. Okay, what foods have sodium? What are the things? I've got to figure out how I get that sodium reduction idea from the concept of what foods are high in sodium to what is it that's going on my fork that I'm going to consume. And I know sodium is one of those areas where it becomes a challenge, especially with the reliance on convenience foods within our current diet, and the amount of hidden sodium that's out there, that we've developed this taste for sodium and kind of a sensitivity for sodium. So when we remove sodium, we're removing this flavor profile that we're used to. It's the same kind of thing that we saw with the low fat reduction. When we went low fat with a lot of different foods, we had to replace it with something because you wanted that same mouth feel when you were eating those foods. So with reduced sodium intakes, you're going to have that same kind of, now food doesn't taste as rich because your taste buds have been saturated. So it takes some time to make adaptations to those changes as well. So it requires a lot more than just kind of this, these are the foods I want you to eat, and now go out and make us proud and eat those foods. So some of the efforts that we've seen around that have been successful in certain situations have been physicians writing prescriptions for fruits and vegetables and writing prescriptions for physical activity. But I know we've all heard individuals frustrated that they have a prescription for medication that they're going to get filled, and now they have to pay for it. The same kinds of thoughts carry forward in writing prescriptions for fruits and vegetables. But the access, the affordability issues then become some of those bigger challenges, where I think we need some more of these team-based care approaches to facilitate these processes. And that's what I'll be talking about next. So next slide, please. So we are lucky within the Ohio State Family Medicine system that we have right now 2 dietitians that serve um, serve the patient, the large patient population within primary care. And we know that that's not always enough, especially with the dietary needs of our population. But the current healthcare system doesn't offer as much reimbursement for nutrition services. So when working with these two dietitians, we did a continuing education course with them, and I asked them, I said, what's the one thing that you really want to know about your practice from an evidence-based perspective? And we developed this QI project to really assess how many individuals were being referred, who was being referred, and how much money was actually being generated as a function of reimbursement. So we didn't have all offices that had, not all offices have access to a staff RD, and a lot of times it's because of the reimbursement. So we wanted to take a look at this from this side of how much can we actually generate. So we turned this into an abstract and submitted this at the annual meeting, which I'll show the data. Next slide, please. So when we were looking at 1 year's worth of data, we were looking to see who was it that was being referred, how much of the time was being spent with individuals across different types of payment. So in red, we have the units of time that were spent, these 15-minute increments. And most of the time was being spent, over half, with private pay or private insurance companies. And the payments were almost 3/4 of how much was generated from the RD. And in this situation, the dietitian was actually able to bring in twice their salary in terms of the amount of billing that they were able to do without even emphasizing who they were seeing and who the payers were and what type of diagnoses were being covered. Most of the diagnoses being referred were for weight management and diabetes, and only 5% for hypertension. So we're starting to see data, and we're going to continue this work that really shows where are your returns on investment, where you can get patients, identify them, and then have a reimbursement model that would allow you to support that more intensive behavioral counseling. So next slide. Thank you. So our other way that we were looking to test this information was to take patients in primary care that had high blood pressure. And we had the physician or the primary care provider refer patients that they felt that would be benefit from dietary counseling. And we were linked with a grocery store dietitian where the physician would refer, we would screen them. We would set up these 3 personalized counseling visits with the dietitian in the grocery store. The first visit was approximately about an hour, and then the 2 follow-up visits were between 30 and 45 minutes. We used a process where the dietitian in the outside could actually share these notes and their care plans back with the physician, so they were within the loop. And as a part of this, we saw a significant improvement in diet quality. We were underpowered for this pilot trial for blood pressure, but we did see an improvement in blood pressure, though not significant. So we were able to dramatically improve diet quality with this model of this partnership. But one of the things that the patients told us afterwards as part of our qualitative piece was they really knew they should do something about diet, but until the physician said, this is really important, I need you to take action, then they made it internalized, and then they were willing to kind of make that next step. So the next slide, just to kind of demonstrate what we were seeing with diet quality. It was roughly an 11-point improvement in diet quality scores from a food frequency. And even if these become the more about what they're telling us we want to know, we're seeing that the education is getting through as well. So these create some great opportunities for partnerships to address these problems. And I will turn it over to Emily.
Thank you, Chris. I'm going to ask people to hold any questions for now. We're just going to move right on to Emily's presentation. Emily?
Okay, good morning, everybody. I just wanted to give a little background. I'm trained as an exercise physiologist. My initial training with adults with cardiovascular disease, hypertension, diabetes, arthritis, and now I actually specialize in pediatrics. So today I'm going to give you an overview of exercise recommendations with a couple key points for hypertension. Next slide, please. We have new exercise recommendations that were just released it was either December or January. This was a 10-year update of federal guidelines that were first released in 2008. There aren't actually any major changes. So we're sticking with our previous recommendation of accumulating at least 150 minutes of moderate intensity aerobic activity or 75 minutes of vigorous intensity activity a week. And so Chris used moderate and vigorous intensity to talk about the amount of time that we are spending counseling patients. When we're talking about exercise, we're talking about how hard the patient is working during their exercise bout. So, we have official recommendations for what moderate is and what vigorous is, but you can use the talk test with your patients to help them figure out where they are. So basically, if they are exercising at a moderate intensity, maybe they're walking with a friend, they can talk, they can carry on a conversation during that exercise bout. If they were at a vigorous intensity, they might have moved up to running or a very brisk walk. They can say a few words at a time, but they're not going to be carrying on a conversation without having to take a break. Now, another key bit of information there is that aerobic activity is accumulated throughout the week. So the intent is not to get 2.5 hours of exercise on the weekend and not get anything during the week. And it also is not absolutely required that we stick with that old recommendation of 30 minutes at a time. People can accumulate in bouts as short as about 10 minutes. They can add up that activity throughout the day. So they don't have to stick with finding a 30-minute chunk of time and feeling like this is an insurmountable hurdle to get over, that they don't have 30 minutes or they can't walk for 30 minutes. If they can do 10 minutes, that's okay. We know that any exercise at all is helpful. Any movement at all is helpful. And that actually might be even stronger for hypertension than it is for some other things. We also have a recommendation to participate in resistance training at least twice a week. And I'm going to talk a little bit more about that in a minute. So if we can go on to the next slide. It is really important for hypertension that we focus on that accumulating bit of the physical activity recommendation. So we know that when someone participates in an acute bout of exercise, after that bout of exercise, their systolic blood pressure will drop. As soon as they've recovered from that exercise bout, their systolic blood pressure will drop 5 to 7 millimeters of mercury, and that decrease lasts about a day. So if we are then accumulating physical activity over the course of the week, a little bit every day, then we are maintaining that post-exercise hypotension. And so we're not having to wait 2 weeks, 4 weeks, 6 weeks for a decrease in systolic blood pressure. We're actually getting it right away. We also know that if we are moving every day, that helps us promote burning enough calories to assist in weight loss. And of course, we all know that weight loss is important for management of hypertension. Physical activity is not, I wish it were, it's not going to be your front line for losing weight because we just have to do too much exercise to burn a significant number of calories. But it's a really excellent addition to the dietary changes that Chris was talking about. And it helps us just tack on that little extra bit of energy expenditure that might push us over the hump and start reducing body weight a little bit. We know that both moderate and vigorous intensity activities are effective. People who have hypertension might feel more comfortable staying at a moderate exercise intensity because their increase in blood pressure during exercise won't be as much with that moderate intensity bout as it would be with a harder bout of exercise. So if anybody is worried about having hypertension during exercise that might get to an unsafe level, we can keep them down in moderate intensity exercise and make that less likely to be a concern. The final bit I wanted to talk about here on this slide is high intensity interval training. That's what that HIIT means. This is very popular exercise lately, and so I expect that you will hear patients asking about it. This typically is characterized by a really short high intensity effort. So 10 seconds, 30 seconds on a treadmill running as fast as you can, or on a bike pushing as fast as you can. And then a recovery interval that's usually 30 seconds to a minute, depending on how long that high intensity interval was. We don't have as much information about that for hypertension. It's much newer in its popularity, and so we're not really sure about what the risk of hypertension during the exercise bout is for that. So we're really sticking still mostly with that moderate and vigorous, continuous, dynamic exercise for hypertension at this point. Next slide, please. So as I said, it's primarily rhythmic, dynamic exercise. So walking is an excellent example. Running is an excellent example that sometimes is very intimidating to people. We also have lots of good options that are not solo activities or are not necessarily quite as structured as going out for a run. So people could participate in group exercise classes where they can be in a group environment and, you know, pick up on some of that positivity from other people. Dancing, cardio machines, whatever people are interested in that moves most of their muscles, where their body is moving rhythmically, continuously for at least 10 minutes at a time, we're going to start seeing that improvement. For resistance training, we don't have as much evidence. Again, with hypertension, we've been pretty cautious in our research studies. We know that dynamic resistance training, which is really what you normally think about if you go into the gym and you're using weight machines or dumbbells, resistance bands, doing push-ups and sit-ups at home, all of that is dynamic resistance training. Static training is isometric stuff. So you're pushing against something, but we're not seeing a lot of joint movement there. We know that we get a greater increase in blood pressure with static resistance training than with dynamic resistance training. So I would stick with that traditional type of resistance training with machines, dumbbells, bands, and things that we think of, because we know that that acute increase in blood pressure is not as much there. The other thing I want to point out about resistance training is that it's very important that our patients continue to breathe during that loading part of resistance training. So during the exertion part, the part that's hard, it's important that patients are continuing to breathe rather than doing Valsalva, because we know that Valsalva will spike blood pressure real quick. So just, you know, be communicating to your patients, moving their entire body, continuing to breathe, either whether it's aerobic exercise or resistance exercise, as it's dynamic movement. We're not likely to get our blood pressure high enough to be dangerous, and we are likely to have a decrease in blood pressure right after that exercise bout. Next slide, please. So I wanted to leave you with a few resources that I think are excellent for providers. If you haven't heard about the American College of Sports Medicine's Exercise is Medicine campaign, this has been going on for, it's actually probably been about a decade. The goal here basically is exactly what it says, is to get patients and doctors to start thinking about exercise as another form of medicine. So they have sections of their website for healthcare providers, and they have sections of their website for patients. If you go to the healthcare providers section of the website, they have an action guide there for you that's already put together. They have forms flyers you can hang up over your office. They have forms you can use to fill out an exercise prescription. They have prescription pads you can use to give your patient an exercise prescription, just like Chris was talking about giving a diet prescription. Billing tips, lots of extra resources available for you, because I know this isn't something that you get to necessarily to spend a lot of time thinking about and talking about, and can be a little bit tricky. For your patients, with this most recent increase or update in our exercise recommendations, the Department of Health and Human Services launched this Move Your Way campaign, which is kind of similar to My Plate in the sense that patients can go to the website, they can there's a lot of different problem-solving tools on there, so they can use these tools to kind of set up their own exercise plan and figure out what they might enjoy and plan out how they're actually going to incorporate this into their week, so that since we know we make these plans, we make these goals, we're much more likely to actually stick with them. So that, I believe, next slide, I think that's all I had. Yes. So yeah, that was a real quick update, but I'm happy to take any questions when it's time.
Thank you, Emily. I want to go back to Chris. I think this question is directed at him. It's from the Cincinnati Health Department, and Anissa Shomo was asking. I think she's asking about the actual practice at OSU. What is the payer mix of your office, as she has mostly Medicaid, Medicare, and uninsured patients? Chris?
So it is a mix of payers that we have. So being Ohio State, we do have a large Medicare and Medicaid population, as well as private pay. The one thing that I will say is that CMS has been starting to make some changes around what they will cover, the well care visits, weight management. The weight management is set up that it needs to be in the office and facilitated by a PCP or designee. So there are some capabilities within that, within Medicare and Medicaid. And that's where I think being strategic about knowing who will pay and for what allows you to get the funding started, and then you can branch it out to whomever else kind of can fill your extra slots kind of scenario. And that's where we've really needed to go on our next steps as well.
Thank you, Chris. Emily, I just had a brief question for you as well. So, patients who are doing exercise stress tests, for example, their systolic blood pressure goes really quite high. And I think you're intimating this, what I believe as well, is those temporary spikes are not harmful in the long run. I mean, it's scary a little bit, but whether they're doing a bench press or whether they're, on a treadmill, doesn't seem like there's any long-term consequences. Is that correct?
That's correct. If a patient has more advanced hypertension where their resting blood pressure is really very high, then the risk is going to be highest amongst that group. We know during dynamic exercise, for a continuous exercise bout, we would like patients to keep their systolic blood pressure under about 220 millimeters of mercury. Obviously, many people are not exercising in a medically supervised setting where they could actually have their blood pressure checked during the exercise bout. But if they're doing stress testing, that blood pressure monitoring should be occurring during the test. And so the exercise physiologist who runs that test should be able to prescribe a level at which the blood pressure remained at that safe point.
Great, thank you. I think we'll take one final comment from Dr. Aurora. Is anyone aware of any resources in the community for a patient population to be able to obtain healthy food at a more reasonable and affordable cost? This is in Fremont. It is expensive to eat healthy all the time. That is true. I don't want to get into too many details about this, but the USDA has done studies that have shown that in some ways it's less expensive to eat healthily than to eat a typical diet that many of our patients consume, which is high in fat and calories and salt and from fast food restaurants. Nevertheless, there is that perception out there, and there are resources, I think, to assist people. I believe the health system in Toledo, I can't recall the name, I think it's ProMedica. They are very progressive, and they have grocery stores in some of their hospitals, and food prescriptions can be filled there as well. But Chris or Emily, do you have any comments about that?
I would say this is probably another opportunity to be using the other staff within the office, especially social workers, the ability to get them linked to food assistance programs. The number of programs that exist that can be out there for support, especially for individuals in low income, can be a great opportunity here with that partnership. So I think it's one of those things, you don't have to solve all those problems, but being able to make the linkages becomes one of those more important aspects.
Right. And I just want to give maybe a final opportunity for Adam to address the issue of income and food insecurity and diet to some extent. I mean, basically, how much of a barrier is income and poverty to eating healthily.
Well, I mean, I think even it looks like there's a comment from Dr. Aurora that oftentimes healthy foods can be far more expensive. And so it's, I mean, I think, so there are two dimensions here. One is if there are resources nearby that you can connect your patients with, that's great. There are these services like Healthify and Aunt Bertha that allow you to do a zip code lookup to see what food resources are available. Now, a lot of those are food emergency resources, and oftentimes your local sort of charitable food pantry is fully stocked with high salt canned foods. So those folks who really end up in a bind because they need food and the only food available tends to be very high salt. But I think the things that Chris and Emily talked about are even more critical in that situation. So just because someone is in a situation where they are dealing with food insecurity doesn't mean we should forego talking to them about the need to eat healthy, to read labels, to limit salt, and to exercise. In fact, it sort of, if anything, it magnifies the importance of that. And Dr. Rao, I can put a couple of the links to that in the chat box. It looks like there's another comment about matching SNAP dollars for farmers markets, and there are in fact lots of programs statewide where folks can sort of double their money on SNAP. So if they're on the SNAP program for food, that if they're making healthy choices, they can sort of make those SNAP dollars go a little bit further. That's a nice incentive that's available in some areas.
It's some great points. So we know through literature going back a number of decades now that the number one thing that determines food preference is taste, followed by price, and then convenience, and then nutrition is in fourth place, in generally speaking, with a lot of our patients. So anything you can do to attack some of those first three factors. So the SNAP programs, I think, are a good example where you're taking cost, you're mitigating cost to some extent, making healthy food more convenient, making the healthy choice the easy choice, of course. Taste, of course, you have to work on at a very, very young age, which I used to do quite a bit of as well. So, but thank you, and thank you for the link, Shannon. Okay, I think we're going to send it back to the hub. Shannon?
Thanks, Dr. Rao. Thanks everyone for presenting very quickly. We are still advertising for the upcoming conference, May 17th in Columbus. The poster sessions, I believe, are closed. However, registration is still open at cardio.org, cardi-oh.org. And finally, you will have a survey in your inbox to complete after the session today, and please, you'll have until about 5 o'clock tomorrow afternoon to fill that out. And next week's clinic is presented by Dr. George Bakris from the University of Chicago, and the topic is Overview and Treatment of Resistant Hypertension. And we can't wait to see you all then. Have a great day, everyone.
Thanks, everyone. Have a wonderful weekend. Bye-bye.